Assalamu alaikum wa rahmatullah. This presentation about KPIs. At start, we have to take about the indicators and the KPIs. We'll give you some definitions and concepts. The rule is we cannot manage what we cannot measure. So we cannot do anything with what we don't know anything about it. We don't have a measure for it. Again, we cannot improve what we cannot measure. If we cannot measure something, we cannot improve it. So without measuring, we have just a math. We just have some numbers or facts or something. Without measuring it, we cannot improve it. We just have an assumption about this thing. What's the definition of indicators? Indicators are reliable and valid measures used to assess or screen organizational or practitioner performance issues. If we want to assess or to measure or to screen organizational or a practitioner individual performance, we have to use the indicators. Those indicators should be reliable and valid. We will discuss now what's reliable and what is valid. So this is measuring or using KPIs. What's the distance between Al-Qunfuda and Jeddah? This is a question. If anyone is asking you this question, you can find a lot of answers. And those answers are inadequate, insufficient. Like, it's very far, it's very near, it's considerable. So far, we don't know what's the distance. We did not measure it. We do not have a rigid number for it. We don't know how much it takes a time to go to Jeddah so far. So without measuring, we cannot say what facts we have. What are the characteristics of good indicators or for good KPI? Your measure or your KPI or your indicator should be objective. Objective means factual and based on observation, not assumption. Should be measurable. We can measure it through a number or percentage or ratio or rate, so we can measure it. We can catch something in our hands. Should be valid. Valid means the degree to which the intended measure is achieved. Measurement is achieved. What it's intended to do. It can measure what it intended to measure. What about reliable? Reliable means repeated measures will give the same results. So yield same results on repeated testing. If I'm repeat this test a lot of time, if I'm collecting those data, I will achieve the same results. That time we will call it reliable. A lot of healthcare givers have a misbelief about valid and reliable. To make it very simple to you, just look at this picture. If you or anyone is playing darts, if you know darts, and you're trying to get your dart in the center, in the middle of this picture, what do you have to look at? Look at the first one on the left side. This one is reliable but not valid. Reliable means if you try to play your darts or to shot your darts, how many times it's very close, it's almost in the same area. So it's reliable. Reliable means, as we said, repeated measures, repeated test will give the same result. But this one is not valid because validity, we are aiming to the center and we did not reach the center. As you see here on the left side, no single dart aim or reach or be in the middle of the circle. So this one is reliable, but it's not valid. The left one, the second one from the left side is a low validity, low reliability. As you see here, he shot a lot of darts, but no one of them is close to the other one. It's very far from each other, so it's not reliable. And at the same time, we did not hit the center, so it's low validity. Third picture is not reliable and not valid. As you see here, it's very far from each other, so it's not reliable, and it's not close to the center, so it's not valid. The last one is the reliable and the valid measure. All the darts he shot or you shot It's inside the middle of the circle, so it's valid. And it's very close to each other, so repeated sending of the dart will be almost in the same area. So this one is reliable and valid. So evaluating the validity and reliability of refreshed data is what's happening in those circles. Your measure again should be comparative. You can compare it to yourself or to others. To others and yourself, we will call it benchmarking, and we have a special slide for benchmarking. And at last, based on standards of care, practice, clinical guidelines, always make your standards, your indicators, your KPIs, studying or circling or rounding around the most important processes inside your healthcare facility, and based up on clinical practice guideline or according to standards. What are the types of indicators? We have a lot of classification of the indicator, but the most important one we are focusing on is structure indicator, process indicator, and outcome indicator, which is the Donabedian triangle. Structure, to make it easy for you, it measures the input and the resources allocated to provide care. Any process you are studying, anything you are try to measure inside your healthcare facility, look at the structure, the resources you need. So what are the resources? Examples of the resources: people are resources, medication inside the hospital are resources, computers are resources, paper, printers, beds, money, spaces. All of this, if you are measuring it, you are measuring the structure. This is the people, the computers, the medication, and the beds or the rooms or the facility or the spaces itself. The other type is the process indicator. Process means the steps, the activities. So it measures a discrete activity that is carried out to provide care or services. Like what? Like treating people, like dispensing medication, like discharging patient, like doing operations, like analyzing some data. All of these are processes. Examples of the processes: consulting people, doing some surgery, and dispensing medication. All of this we will call them the second type, which is the process indicator. The third one, which is the outcome indicator, which measures the results of the process itself or the operations itself. So it measures what happens or doesn't happen as the result of the process, like the outcome, the results, the output, like absenteeism of the staff, like morbidity, mortality, like patient falls, like healthcare acquired infections, and so on. So the outcome is the net result of your processes or your operations. So this is a classification or types of the indicators. We have a lot of indicators required by SIBAHI. SIBAHI will tell you that you have to establish or to measure those KPIs, but not limited to. This means at least those indicators, and you can add anything more. So I will give you some examples of SIBAHI. SIBAHI will classify indicators into structures. Indicator like availability of essential supplies, availability of blood and blood products, availability of emergency medication, vacancy rate of all staff. We will consider this one structures, input to start to do the job. The other one is the processes, steps of the processes, like using antibiotics prior to surgery, blood administration, documentation in medical record, and delays in answering phone call or blips from physicians. So for SIBAHI, classifying it into structure, process, and outcome. Examples of outcome indicator for SIBAHI, like mortality rates, nosocomial infection rate, patient satisfaction rate, staff satisfaction, unplanned return to OR, unplanned transfer to ICU, CPR, failure or success rate, readmission after 3 days of discharge, OVR, and medication errors. So the classification of SIBAHI is matching with what we said now, structure, process, and outcome indicators. We have another classification according to the GCI, Joint Commission. They are classifying or requesting KPIs in two types, managerial and clinical. The managerial, like patient demographics, availability of essential supplies and the medication, reporting activities, and financial activities. What about the clinical indicators like laboratory activities, like turnaround time, for example, radiology activities like surgical procedures, like antibiotic use, like medication errors, like anesthesia use, blood and blood products use. So this is a classification of infection control of GCI classification or types of indicator requested by the GCI. The main types here of the indicators is rate-based indicators and sentinel indicator or sentinel event indicator. Rate-based indicator, what's the definition of rate-based? It will assess an event for which a certain proportion of the event that occur in the time period represents specific care or service or has a specific outcome. Rate-based means a numerator and denominators. And only on one condition, the numerator should be a part of the whole denominator. So it's considered a proportion of it. Like what? Like falls, fall cases. Fall cases is the number of patients that have fall divided by the total number of patients. So patient with fall is a part of the total patient admitted to the hospital. The other type is sentinel event indicator, which shouldn't happen. We will not allow it to happen. And when it happens, we have to do an investigation. We have to do a root cause. We have to study why it happens. It will assess a serious or significant event that requires further investigation for each occurrence. If it happens at least only once, we have to do investigation for that event. Example for it, wrong baby identification or delivery of a baby to a wrong family. We have 21 central events, and I believe that we mentioned it and discussed it in the risk journey presentation. So, could be the fall itself a rate-based indicator, and it could be a sentinel event indicator. How? If we are calculating the number of patients that fall over the total number of patients admitted to the hospital, it's a rate-based, multiplied by 100, of course. So we will call it rate-based indicator. But we can consider it also as a sentinel event because it shouldn't happen. So if we have single patient fall down, we can study it as a sentinel event indicator, not sentinel event as a definition of sentinel event, because we don't like that patient will fall inside our healthcare facility. So single occurrence of a fall may be considered as a sentinel event indicator. How we can develop an indicator? How can we plan to developing an indicator? We have to go through some steps. Step number one, identification of important organizational function based on a scope of service. Look at your scope of service and look at what kind of indicators you have to select. We can select or collect thousands of indicators, but we have to focus on main indicator. We call them KPIs, key performance indicators. It should be considered or should be focusing on the indicator that taking care for the organizational function, important organizational functions. So what are the criteria for selecting a good indicator? The indicator should focus on the high volume processes, something we are doing it a lot inside our healthcare facility, like admission, like discharge, like transfer. We have to search for high risk. Anything that could give risk to the patient, we have to focus in. Problem prone, we will find a lot of complaints against that process, so let's do a KPI for it. High cost, any process inside the hospital that costs us a lot. It can cost us lives, can cost us money, so that time we have to do indicators for it. And at last, complex interdisciplinary things. It's KPIs that discuss interdisciplinary, something related to a lot of department, better than estimating or focusing on KPI related to single department. Step number 2, identification of a scope of care within each function when we have to start to do this process and the end, so we can select our KPIs and focus on the total process from point zero until the end. 3, identification of process that have significant impact on the patient outcome, as we said that if it's high volume, high risk, problem prone, high cost, or complex. 4, development of preliminary set of indicators, how to develop the indicator itself. Then we have to make the indicator card, putting every single required data for that indicator before training people and giving them that card so they can implement that card easily. We will discuss a lot of cards at the end of this presentation. Information set for an indicator. What kind of informations that we need to start an indicator? Number 1, indicator statement. We have to put a statement for that indicator. Number 2, we have to make a operational definition for it. What kind of patient will be with us? What kind of patient we have to exclude? What kind of steps we are going to measure, and what kind of steps we have to overrule. 3, rationale of choice. Why we selected that KPI. Is it high risk? It's problem prone? It's high volume? It's interdisciplinary? 4, dimensions of quality being assessed. Again, it's high risk. It's required by SIBAHI, required by leadership group. It's an MOH required. It's a risky indicator, and so on. Types of indicator. Is it structure, process, outcome, threat, or it's an central event indicator? Formula, you have to tell me how can I calculate it. Do you want it from me as a number, just rigid number, or volume indicator, or you want it is a rate base or a percentage? So what's my numerator, or what's my denominator, and how can I calculate it? 7, data collection tool. Do you have a data collection tool? I will use it. You have to give me a data collection tool so I can collect data inside this tool. 8, data collection methodology. What kind of methodology? What kind of sampling technique I will take, or I will take all the population with me. 9, data is collected by who? Who have to collect it? Is it by nurses? Is it by total quality management? Is it by infection control department? Is it by clinical audit department? Is it by physicians who have to collect it? 10, frequency of data collection. I will collect it daily, on daily basis, weekly, monthly, quarterly, mid-yearly, yearly, one shift, morning shift, night shift, and when. 11, route of reporting. How can I will report it? Paper or through an HIS? Then what's the compliance, benchmarking, and the trigger? When we have the trigger, the indicator, sorry, KPI, what I will do with this indicator, what I will do with those numbers or percentage or figures, I have to check, is it compliance with the benchmark that comes from MOH or from international bodies, or from governing bodies, or from accreditation bodies, and there is a special slide for the benchmark. I'll give you some examples of the indicator cards. There is simple one, there is a more detailed one, there is some KPIs coming from clinical audit, so let me offer some of them. This is an example. Elements, indicator title, rate of falling down patient. So this is the name of the indicator. Dimension, it's care, related to patient care. Type, it's an outcome indicator. Formula, the numerator will be the number of falling down patient divided by number of patient at high risk of falling. So you have to tell me what kind of numerator and denominator, because if you did not tell me, I can take a lot of things and I can give you a lot of KPIs related to patient fall. For example, I'll tell you that I have 9 falls that month, so it will be a rigid number. Or I can tell you that number of patient fall divided by number of admitted patients. And here he chose another one, number of falls over number of high-risk patients to fall. Objectives, patient safety goal. It's concerning about patient safety. Data collection tool, I will take it from OVR. Data collection methodology, I will cover it 100%. I'm not example of people that fall down. I will take them all. Frequency, I will collect it monthly. The benchmark, you have to benchmark or you estimate or you're comparing your results to that result. Below 0.1. If you are over 0.1, you have to do something. If you are below 0.1, it's okay. Another example with little bit more details. So from where I will got my information about the KPIs. I can take it from the patient medical record, from the OVR or risk register, from the clinical reports or case reviews, from the peer review, from quality reports and checklist, from rounds and records, from patient demographic and registration data, from surveys and from direct observation, or from reports coming from MOH or covering body. What's benchmarking? We mentioned that the benchmarking, we have to estimate ourselves or comparing ourselves to the benchmark. So what's the benchmark? The benchmark is a process of measuring the performance of a company, product, services, or even a person or a process against those of another business considered. Take care of the word considered. To be the best in the industry or in the healthcare, like best in class. You are comparing yourself to the best one. The points of benchmarking is to identify internal opportunity for improvement. So the total aim of benchmarking or comparing yourself to a fixed number, universal number, best numbers is to just improve yourself or improve your processes or improve your healthcare facility performance. Okay, so from where the benchmarking word came. If you know the tailor, the one who will make the dresses for us, if he want to estimate the length of a piece of clothes, he will use a rigid meter made of plastic or meter. So he will search for it, get it, and he say 1 meter, 2 meter, 3 meter. To avoid doing this a lot, what he did, or a lot of them did, they came to their desk, the desk they are using, and they will put marks, 2 marks, mark from here to here is 1 meter. So now no need to use the metallic or the wooden meter. They will use the desk itself because they will bought a fixed place, and this place is almost 1 meter. So you are comparing yourself or comparing the closest to this points from point 1 to point 2, it is 1 meter. If it's more, so you are not matching with 1 meter, you are giving those people more than that they deserve. And if the piece of the closest is little than this space, it's lower than they deserve. This is the benchmarking. What are the types of benchmarking? We have internal benchmarking and external benchmarking. Internal benchmarking, you are comparing your performance day to day, shift to shift, week to week, month to month, year to year, one department to one department. What about patient to fall regarding male medical and female surgical, for example? This is an internal benchmarking. Your performance morning and evening, how many patients have CPR failure rate in the morning and the evening. This considered as an internal benchmark. What about external benchmarking? You are benchmarking your hostel to another hostel. And those hostel could be accredited or international hostel or well-known hostel or a reference hostel. You're benchmarking yourself to it. So we have 2 types of benchmarking, the internal benchmark and the external benchmark. Here a very, very detailed KPI. They are, name of the KPI, percentage of women aged from 40 to 69 years old screened for breast cancer using mammogram during the month. What's the rationale? Why we are estimating it? Because we want to do early detection of breast cancer women between 40 to 69 years old by mammogram. What would be my inclusion and exclusion criteria. What's the numerator and denominator? The numerator will be, or the inclusion, who will I take in my KPI, the number of women aged 40 to 69 screened for breast cancer by mammogram during the month. And the denominator is the number of women the same age targeted or I want to screen. So number of screened already divided by the total number I targeted to screen. I plan to screen them. Exclusion criteria, who I will exclude from my KPI, woman screened outside the age group. If I screened a woman 35 years old or 75, we will not consider it because it's outside my range group, and other age group. Sources of data, from where I will get it? From the medical record of early detection clinical of breast cancer, or from the radiology department, so I can get it from there. The formula, as we said, it's the number of females from 40 to 69 that screened over the total number I targeted to screen during a month multiplied by 100. So it will be a percentage, and the unit is a proportion of breast cancer cases. The grouping is regions. I will take it in my region. What is the sampling rule? Targeted will be calculated with the period inside the month itself. Indicator level, it's operational. Category, it's productivity and efficiency. I will check what's my productivity of the mammogram department. The benchmark, if I have a benchmark, I will put it here. If I don't have, I will put it a target, what I will do, or I can put it as a trend, increasing or decreasing. The threshold, I will make it for myself. I will call myself green if I'm more than 75%, amber if I'm between 50 to 74%, red if I'm less than 50, and black if it's 0 or did not started yet. Data collection responsibility, I will give it to the people in the mammogram department, radiology. The coordinator, who will be the coordinator, I will collect it monthly and I will report it monthly. So simply I have now a full indicator card. I use it. Another example, I took it from the clinical audit in one hospital. Name of KPI, percent of patient readmitted to ICU within 48 hours of discharge. If we have people came again to the ICU after I discharged to the ward within 48 hours, this means that something wrong is happening inside our ICU and I have to study it. The rationale, readmission to ICU result in an increased consumption of medical resources and cost, and have proposed as a maker of quality of care, it reflects the maturity of discharge. Did I discharge these people from ICU in the proper time, or it's a premature discharge? It's discharged against the criteria or not, or matching with the criteria. The grouping, length of stay in the previous ICU admission, diagnosis, cause of admission, all those areas I have to study. The benchmark is less than 4%. If I have 100 admission this month to the ICU and I discharged them, it's okay if I found that I have less than 4 of them readmitted to ICU again. Anything more than 4%, I have to study it. It's applicable to our adult ICU, pediatric, neonatal ICU. Exclusion, numerator and denominator. Discharged against medical advice. Someone ICU, he said that I have to go outside. Patient shifted out from ICU to operation. I did not shift it from the patient, sorry, from the ICU to the ward. I shifted him to OR because he in need to an OR. Then readmitted to ICU again, I will not take him with me. The formula is total number of patients readmitted to ICU within 48 hours multiplied by 100 divided by the total number of discharged from ICU. Another 2 examples you can, because I want to go to the last slide. Finally, after we collected our KPIs, what I have to do? You have to validate the data, revise the data again, try to allegate that you are calculating the data or collecting the data again to make sure that those data are valid, they are correct. Then you have to put them in a tables or a graph or dashboard with colors to give them to the leadership group so they can make a decision on them. Always after you collecting your KPIs, make a corrective action plan if your target is not being attended. If you have, as we said before, if your number is above or below what's the intended, if it's good, you keep it. If it's bad, you have to do a corrective action plan. Go to people, tell them what's right, what's wrong. Like the example we mentioned in ICU, go to the people, ask them, where is your discharge criteria? And revise the medical record. All of those patients discharged from ICU and they come back after 48 hours, did we discharge them with this criteria, or we discharged them against the criteria so they came back? Thank you very much for your listening. If there is any question, please feel free to ask me or send me on my email or on what our WhatsApp group. And don't forget to look at the other presentation on our YouTube channel, Quality Tabib, QUILTY TAPBEEB. Thank you very much. Until we meet again. Assalamu alaikum wa rahmatullahi wa barakatuh.